Welcome to this week's episode of Jing TV. Who are you?
See how formal it's become? Hello viewers, my name is Meghan Mari.
I'm Rachel Fairweather, and we are the directors of Jing Advanced Massage. What are we called now? Right, okay. I have a question from a lovely student who's been with us for a very long time called Hilda Harvey.
Who's also, become one of our teachers as a student, isn't she?
Absolutely, yes. She said, shoulders, lots of shoulder problems around. Is it neck? Is it pelvis? Is it thoracic? Ideas, please, Meghan Rachel. Also, serratus anterior / posterior always seems to be stuck down and painful. So, lots of thoughts.
Okay.
Neck, shoulder, what is it?
Okay.
Right. Okay, what do you think, Meghan?
All right, so if it's a shoulder concern or they're indicating I hurt here, you have to go to the area of pain first, right? So Hilda's question, which is a very informed question about is it the pelvis or is it the thoracic, I think maybe, and you get that from doing some gait analysis, doing some body reading, checking in with someone around how they use their body and what's going on. But I always think in the first instance, i.e. the first treatment, if not also the second treatment, you really have to go to the area of pain.
It's sort of like don't make it too complicated in the first situation. So I, as Meg said, I mean, the bread and butter thing that we always do at Jing, check all the muscles around the joint for trigger points and fascial restrictions and just start there. Don't be getting into some complicated body reading situation.
And with neck and shoulder problems, I always think it's really important to do, as I know Hilda will be doing, benchmarking around range of motion. So helping them to understand the difference between flexion and extension of the cervical spine versus elevation and depression of the scapulothoracic joint versus abduction and adduction, flexion and extension of the glenohumeral joint. So, being able to cleanly look at each of those ranges of movement and all the rest of them that each joint can do, you start to educate your client around what's actually problematic. Then you're going to go global specific, right? So then you're going to do deep tissue work or just gorgeous forearm effleurage around the area, maybe a bit of heat, go in for the trigger points, and then your fascial work might have been before that. So you're kind of looking at that. Serratus anterior, serratus posterior being stuck down all the time is for sure. And I think I always get best results if I go side lying for that.
For serratus anterior.
For serratus anterior.
Serratus anterior is the bunch of bananas shaped muscle that lies on the side.
And going in with like soft fingers along the rib cage. And also I think for this particular area, getting them to do lots of STR or structural integration fascial work. So you're getting them connected to the area and then asking them to do some movement can really make a difference, again, around that education. And that might be also true for the pelvis. So if you think there's a correlation, it often tends to be on the diagonal. So if it's the right shoulder that's problematic, it's usually the left hip that's out. But you'll have to look and play with that.
I think the other thing with serratus anterior is that because it attaches to the medial surface of the scapula, some of those fibers actually go really high up, so you can work quite high up into the armpit to actually release some of those fibers. I think we show it in one of the chapters in the Jing book. And the other thing I would say from overall kind of global body reading, particularly with sort of like neck issues, the posture can often be involved. One of the most common overall patterns is to have what's called an anterior pelvic tilt, where the pelvis is tilted forwards. That causes the rib cage to shift back, and that then causes the neck to kind of stick forward. So if you're just trying to release the neck and you're getting results, then you might need to look at the patterns a little bit further down. We look at that more on like the structural fascial body work, those kind of aspects of body reading. And actually do not forget the other issues that might be involved in someone's pain condition. So it's not just about the tissues. We always say it's not just that the issues aren't just in the tissues, but the pain is in the brain. So if somebody's got long-standing chronic pain issues, you might have released all the tissues, you might have done all the good stuff you're supposed to do, but maybe there are other issues that are contributing to their pain, such as their thoughts about the pain condition, beliefs such as I'm not able to move it, I can't do this and I can't do that. And again, I talk about that a lot in the book, so that is also something that you need to educate and work with your clients on.
Thanks everybody, and thanks Hilda.
You.